Hello everyone, I am Nina Agbayani, Director of Programs at APCHO. On behalf of APCHO, I welcome you to the third in a five-part series of APCHO's Practice Transformation webinars. APCHO is a national association of 35 community health organizations dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian Americans, Native Hawaiians, and other Pacific Islanders. With the rapid changes that are occurring within the healthcare landscape, we hope we can better serve Asian American, Native Hawaiian, and other Pacific Islanders serving community health centers with latest information on practice transformation. The goal of this series is to provide you with the latest on quality improvement, meaningful use, accountable care organizations, and patient-centered medical homes, and explain how they affect all of you and your clinics. In the last webinar of this series, we'll also be providing you with an analysis on the culture and language access standards that we are seeing in these practice transformation efforts. Today's webinar is entitled Patient-Centered Medical Home, Implications for Community Health Centers Serving Asian Americans, Native Hawaiians, and Other Pacific Islanders, and our speaker is Ignatius Bao. Ignatius is a leader in health policy analysis, particularly around patient-centered care and healthcare reform. Prior to establishing his own consulting practice, Ignatius was a program officer and program director at the California Endowment, director of health policy and programs at the Asian and Pacific Islander Health Forum, and civil rights and immigration law attorney at the Lawyers Committee for Civil Rights of the San Francisco Bay Area. He was also part of the community efforts that resulted in the creation of the first White House initiative on Asian Americans and Pacific Islanders, and was a principal author on the first report from the President's Advisory Commission on Asian Americans and Pacific Islanders. Ignatius is a champion for Asian American, Native Hawaiian, and Pacific Islander community, and a great APCHO supporter and ally. We are honored to have him with us today for this five-part series. Today's agenda will include a 45-minute presentation and 15 minutes for Q&A.
And so the slide you're looking at now, we are looking at an example of the go-to webinar attendee interface, which is made up of two parts. The viewer window, shown here on the right, but maybe on the left of your screen, depending on your browser or computer operating system, allows you to see everything the presenter will share on their screen. The control panel shown here on the left, but maybe on the right of your screen, allows you to participate in the webinar. By clicking the orange arrow button, you can hide or show your control panel. You can also set the control panel to auto-hide or not to auto-hide by going to the View menu. Please note that all attendees are in listen-only mode and will be muted during Ignatius's presentation. You may submit questions in writing during the presentation by typing them in the questions field. We will be reviewing questions as they come in and will address them during the Q&A session held after the presentation. Today's webinar is being recorded, and you will receive an email with a link to view a recording of today's presentation after the webinar. And with that, I'll pass the meeting over to Ignatius.
Hi, everyone. This is Ignatius. I'm really happy to be able to share this webinar presentation, the third in our series on patient-centered medical homes. And I think this in some ways is appropriate for being the middle webinar in our series because it really is the core of the practice transformation work that many of you are going to be engaged in. And so the objectives of this webinar are really to explain what the patient-centered medical home concept is, and then talk about how healthcare reform and the Affordable Care Act in particular have supported the patient-centered medical home concept, and then finally what the specific implications might be for community health centers who are serving medically underserved Asian Americans, Native Hawaiians, and Pacific Islanders. So just as a reminder, we've been talking about the triple aim, which is really the framework for healthcare reform implementation, wanting to improve the patient experience of care in the healthcare system as more and more people get insured and have coverage, and are able to access the healthcare system, but also really focusing on the bottom two parts of the triangle of improving population health through quality improvements so that the healthcare system doesn't just give them access, but actually helps them to improve and maintain their health. And then finally, the third part of the triangle, which is to reduce and lower the overall cost of healthcare in the United States. So the concept of a patient-centered medical home has become really, really important in achieving the triple aim and in healthcare reform. It's not a new idea. It's an idea that's very familiar to primary care providers, but particularly to pediatricians and family physicians. It's a concept that was developed in the early 1960s by pediatricians and family physicians for what we call children with special healthcare needs. So children who either have a physical or developmental challenge early in life, and those pediatricians and family physicians realized that once they were able to do what they needed to stabilize that child, that their care for that child often involved coordination with other specialists, with the hospital, with rehabilitation facilities, but then increasingly also began to realize that what really mattered to that child and the health of that child with special healthcare needs might no longer be their health care, their actual treatment, what medication they might be taking, what rehabilitation they were continuing to have, but it really had to do with education, it had to do with transportation, it had to do with housing, and then as the children grew older into adolescence, it actually had to do with employment and other kinds of issues. So it was a real holistic view of what it takes for someone's health, again, to not only maintain and improve it, but really support that individual, in this case a child, in optimizing that health, much in a World Health Organization definition. What the model also really understands is that individuals are not just patients, but have family members, have caregivers, have other support networks, and that if we're going to optimize patient-centered health, we really need to call on those family members and caregivers and community members and others to really be a team around that individual patient. And so this model was then adapted by internal medicine physicians and other physicians for adults, initially with chronic care issues, and then eventually for everyone, that whether it's you or I who might generally be healthy, we would also benefit from this whole person, holistic view of what our healthcare is, and that each of us should have a plan, should have goals for, again, optimizing, maintaining, and improving our own individual health. So the short of it is that this model has taken off. The federal government in particular has been very supportive of implementing patient-centered medical homes. And so the Agency of Healthcare Research and Quality has been tracking all the different initiatives in the various parts of the U.S. Department of Health and Human Services that have implemented patient-centered medical homes. For community health centers, what is most relevant is that the Health Services Resources Administration has partnered with the Centers for Medicare and Medicaid Services to support over 500 federally qualified health centers to become patient-centered medical homes. And they're providing technical assistance, they're providing some funding to support some of the fees involved. And this has, again, been in process. So many of you who come from ACHO member community health centers and other community health centers may have been participating in this and have actually benefited and perhaps already achieved recognition as a patient-centered medical home because of this initiative. What is also rapidly being implemented is also another part of the Affordable Care Act. This is Section 2703 that allows dedicated federal funding for 3 years for states to implement through their Medicaid programs what are called health homes for individuals with chronic conditions. And on this next map, 16 states as of fall of last year have already begun implementing it, and many others are planning the implementation of this to draw down additional federal funding through the Affordable Care Act through Medicaid programs for these health homes. What is also important is that states, even before the Affordable Care Act, have been working on developing medical home initiatives. And in this next slide, you can see the yellow states. Not only were these initiatives underway, but they're actually tied to Medicaid or Children's Health Insurance Program payments. And the orange states have activities underway which are not yet tied to payments. So only a very small handful of states haven't taken this up in their Medicaid or Children's Health Insurance programs. So again, this is another way that this model is being implemented by states. And then finally, this newsflash, many of us were focused on the extension of funding for community health centers under the Affordable Care Act, but as part of that Medicare Access and CHIP reauthorization and community health center funding bill that was just signed by the president last week is also a revision of how Medicare physician payments are going to be made from now moving on into the future, replacing the sustained growth rate formula that was so outdated. And so part of that new formula for how physicians are going to be paid under Medicare are going to depend on those physicians adopting and implementing patient-centered medical homes. And so again, this is yet another way through Medicare that the patient-centered medical home model was going to be driven forward. So let me step back then and do a little more description of what actually is a patient-centered medical home. The Urban Institute counted, and this was back in 2011, at least 10 different models of what a patient-centered medical home might be. These are 4 of the most popular that many community health centers and others have been using by various organizations that have developed these models or standards of what a patient-centered medical home might be. For the purposes of this webinar, I'm going to focus on the standard and the model that has been created by the National Committee for Quality Assurance. This was a model that was first developed in 2009 and then updated in 2011 and again last year in 2014. And the reason I'm focused on the NCQA model is because 37 states, through their various initiatives, whether it's Medicaid or Medicare or their own commercial multi-payer initiatives, have begun to use the NCQA recognition model. So it's the most widely used. Over 35,000 physicians or practices have already been recognized by NCQA in almost every state. And so again, I'm focused on it because it is the most widely used. It's also the model that has been used by HRSA and CMS in the Federally Qualified Health Center Medical Home Initiative. And so again, that's the one that I'm going to focus on. So essentially in 2014, with the updated standards, NCQA has 6 standards: patient-centered access, team-based care, population health management, care management and support, care coordination and care tracking, and performance measurement and improvement. And I'm going to talk about each of these very briefly, but focus on how particularly community health centers that are serving medically underserved Asian Americans, Native Hawaiians, and Pacific Islanders might understand and implement these standards in their own particular context. So first, patient-centered access. This is sort of the opening of really establishing this notion, this concept of having a medical home, having a primary care provider and a primary care team that individual constantly returns to and builds a long-term relationship over really the life of that patient, that engages that patient's family, caregivers, and other supports, and really, again, provides, this is where the concept of a medical home comes from, a place that you can always go back to, a home, something that you can call your own, that is familiar to you, that you have that, again, ongoing, continuous, lifelong relationship with. And so what that requires from the provider standpoint, in this case, community health centers, is that we actually assign individual patients to individual providers. Oftentimes, providers work part-time in our community health centers and have different shifts and schedules. And so it takes a little bit to sort of sort all that out and really create panels of patients for each provider. And then also surround that individual physician or physician assistant or nurse practitioner with others, with medical assistants, with health educators, and really create a care team around that individual patient panel that will take care of those patients with that provider leading that care team. It also means expanded access, so providing same-day appointments, after-hours access in the evenings and on weekends, and then electronic access for some routine kinds of things so that patients don't have to come into the community health center. And this, again, builds on and really is premised on having a high-functioning electronic health record that will allow patients to make appointments online, for example, or fill their medication prescriptions through your dispensary online. So again, doing all those things so that you minimize the inefficient contacts that patient might have to have with your community health center and maximize them getting information and accessing your health center in a way that makes sense for everyone. So particularly for community health centers serving Asian Americans, Native Hawaiians, and other Pacific Islanders, there's going to be a challenge to match those providers up by language and culture, that oftentimes you're serving individuals who speak many different Asian and Pacific Islander languages. And so again, that panel process is even more complicated for community health centers serving Asian Americans, Native Hawaiians, and Pacific Islanders, because you're going to have to take into account not just schedules, but also making sure that you're doing the language concordance and the cultural concordance to the best of your ability. And that's, again, when you have other care teams, medical assistants that may be serving as healthcare interpreters to help you, that is all part of that puzzle. It's also going to be a challenge to provide that expanded access, that again, if you have opened up after hours access, then again, do the providers that you have on shift for those after hours time periods also have the ability to serve patients who speak multiple languages. And then finally, if we are going to use the electronic health record in a patient portal for some of that electronic access, the challenge of doing that in multiple languages with patients who speak multiple languages and who aren't going to necessarily be able to navigate those functions in English is an additional challenge for our community health centers. But again, these are the kinds of things that are going to be required for patient-centered medical homes, and so these are additional challenges, but also really additional opportunities that if we get all that functioning appropriately, it actually greatly increases the efficiency and effectiveness of our provider resources. The second of the 6 standards then is really developing team-based, individualized, personalized, tailored care for those individual patients in a panel. So that starts with a care plan, probably most easily understood with something like asthma, that an individual, whether it's a child or an adolescent or an adult who has asthma, should really understand their medication, should understand when to use the various medications, when to go to the emergency room when they really are having something that they can't control, but also when not to go to the emergency room because there's an alternative of using their medication. And that care plan is something that shouldn't just be for that individual, but should be understood by that individual's family. There might be other things to look at, like the environmental triggers at home that might be longer term of trying to address some of those environmental triggers. And then really making sure that that individual with asthma is coming in for regular checkups to make sure that their asthma continues to be under the best control possible. So that requires a lot of shared decision making. It requires a lot of reminders to make sure the medication is refilled. And it really requires, in this case, a registry of asthma patients in an individual provider or care team's panel so that you can be monitoring all your patients with asthma in your panel to make sure that you're providing the optimal and best care based on care guidelines and based on those care plans that you've discussed and implemented with those individual patients and families. So then again, for community health centers serving Asian Americans, Native Hawaiians, and Pacific Islanders, it's really important that those care plans are in language, that they're culturally appropriate, so that when we're talking about diabetes care plans, that when we're talking about diet changes or increasing physical activity, that those kinds of elements of that care plan are culturally appropriate and taking into account the diet of your individual patient and their family, and then what are the cultural issues. So for many for South Asians, that also means not just changing the diet of that individual or their family, but in the larger extended family in terms of family gatherings where food is served, to make sure that you're engaging the others in that larger extended family and really supporting the individual with diabetes or with obesity or hypertension or with cardiovascular disease in lowering their risk. So it really also means that even the notion of developing an individual care plan pays attention to issues of gender among couples, of parents and children, of deferring to elders in a family, and really engaging all those individuals in a culturally appropriate way and getting their buy-in and sign-off and agreement that this is a care plan that's best for that individual and really best for that entire family. It means paying attention to indirect communication, that oftentimes our patients will just assent and nod and say yes, but really using teach-back methods and other kinds of methods, motivational interviewing methods, to make sure that our patients really understand and aren't just nodding and saying yes, but really understand that this is a plan for them and it's a plan that they really understand and are going to do their best to try to implement. And then finally, as I mentioned last week in the webinar on electronic health records, it really means taking advantage of technology so that we might be sending reminders in English by text to an adult child, but still leaving an automated phone message on the elderly parent's home telephone system in language that reminds them of that appointment. And so again, using the electronic health record and using technology to make sure that something like patient reminders go out in a way that is going to be most effective in reaching that patient and that family and that caregiver. So then the third standard of the 6 is really taking to heart that element of the bottom left triangle of the triple aim, that we're not just about getting people access and developing care plans, but really monitoring those care plans to make sure that health is actually the optimal it can be, whether we're maintaining or improving an individual's health. So that requires detailed documentation of demographic and clinical information, really using clinical decision support, again, based on electronic health record technology, to make sure that we're reminding ourselves as providers of what care is needed, and then using things like standing orders for preventive services so that we're automatically reminding people of immunizations or mammogram and other cancer screenings, colorectal cancer screenings for individuals who are older. And so doing those things really automatically rather than us having to think about, did this individual have those preventive screenings? Are they up to date on those kinds of things? And then certainly for something like diabetes, to make sure that they're getting their annual foot exams and their annual eye exams as well. So again, depending on when you've seen this patient last, all those kinds of things are automatically triggered and hopefully even done before you see the patient. And this is where your care team can help you by reaching out to the patient affirmatively before that patient comes into the clinic to make sure that some of those screenings are already done. Of course, this needs registries to keep track of these panels of patients and what their conditions are and what screenings are due. And it requires things like electronic prescribing to keep track of medication and making sure that the refills are timely and up to date. So again, for a community health center serving Asian Americans, Native Hawaiians, and other Pacific Islanders, this may mean more work with our electronic health record vendors to make sure that we're having disaggregated data by race, ethnicity, and language and other factors, making sure that that clinical decision support also includes things like hepatitis screening and other conditions that are going to be of unique concern to our Asian American, Native Hawaiian, and Pacific Islander patients. And then really using these kinds of standing orders that historically many of our patients have not been very good about keeping up with all these kinds of preventative screenings. And so again, this is a real area of improvement for us in terms of taking the best care of our Asian American, Native Hawaiian, and Pacific Islander patients to really use those preventative screenings to catch things early rather than when it's later on in the course of disease progression. And then finally, or fourth, in terms of the standards of the 6 standards, it's really drilling down and saying it's all fine and good to develop these care plans and to try to proactively reach out to our patients, but how do we actually support our patients on a day-to-day basis when we're not seeing them very, very frequently, really implement their care plans? And so what the patient-centered medical home model recognizes is that we need to also, as healthcare providers and healthcare systems, provide patients, their families, and their caregivers with the support, with the tools, with the information that they need to actually take care of their own health when they're not in our clinic, when they're not in our exam room. And so that means patient education, self-management tools, lots of information, lots of patient and family engagement, and then a referral to community resources. And so for community health centers serving Asian Americans, Native Hawaiians, and Pacific Islanders, it means making sure that all those materials are culturally and linguistically and literacy appropriate, that we're sharing health information through the electronic health record, again, through multiple formats and channels, and that we're really utilizing the community resources that we already know that we often count on for what we know as enabling services within our community health centers, whether it's healthcare interpreting or interpreting for other purposes, whether it's transportation, whether it's enrollment in not only health insurance, but other kinds of programs that are health supports or social service supports or educational supports. And so we've already done a lot of this. And again, this is an area where community health centers are already leaders in healthcare systems in doing this. But again, it's also part of making sure that we're doing this connected to the kinds of care plans that we're trying to put in place for our individual patients in patient-centered medical homes. And then fifth, there's a recognition that while primary care is really, really central and essential and important, that it's not always about primary care, that we're inevitably going to need specialists, we're going to need hospitals, we're going to need rehabilitation, we're going to need occupation and physical therapy, we're going to need a whole host of other kinds of healthcare providers. And so tracking those tests and referrals, following up, and then coordinating care, especially during transitions of care when someone, for example, is in and out of the hospital, either a planned hospitalization or an unplanned hospitalization, that we really need to pay attention and do better about tracking and monitoring and really supporting all those transitions and really stepping up and taking responsibility and saying, oh, that's not something I sent the person to the specialist, but really following up and seeing whether that specialist saw the patient and then consulting with the specialist to say, how can we work together as a team to coordinate the best care for this individual patient. And so for community health centers serving Asian Americans, Native Hawaiians, and Pacific Islanders, we're often challenged in creating those specialists in hospital networks, and we're going to have to continue to work to strengthen those networks. And again, other things in healthcare reform where those networks are also being pushed to do better coordination with primary care can help support these kinds of network buildings. There's a lot of attention, for example, in transitions of care where hospitals really want to reach out to primary care providers and work to improve their transitions of care to lower the readmissions that are coming into those hospitals. Emergency room utilization also is a big issue for hospitals, and so again, they're eager to reach out and partner with primary care providers to decrease their emergency department utilization. This will also really require, as I mentioned in last week's webinar on health information technology, that your local area supports robust health information exchange among all these providers in the healthcare system. And then for something like medication reconciliation, really pushing to include herbs and supplements and complementary and alternative medicine in that medication reconciliation, so it's not only something that you ask, but it's also something that you're discussing with the hospital, with the specialists, with the other providers as you're trying to improve these care transitions and these points of care coordination with the other providers, all for the benefit of your individual patient. And then finally, the most important part of the patient-centered medical home model is that we shouldn't just see this as a static model, that once all these elements are put in place, that we can just rest and say, we've done our part, we've put in the model, but it really requires this continuous sense of quality improvement, this dissatisfaction with where you are and always wanting to do better, always wanting to improve. And so it requires measuring quality. That includes measuring patient experience of care. So the top part of the triple aim is really putting more and more emphasis on measuring patient satisfaction in a number of ways, not just with surveys, but really doing other things like focus groups, like looking at your waiting room, like sitting in your waiting room and seeing what it's like and how you can improve patient flow through your clinic. And then really publicly reporting all these measures either to public health authorities, to payers, but also ultimately back to your patients and communities through your board, through patient advisory councils, and to the community at large to say that you're transparent and accountable about these quality improvements. And so for our community health centers serving Asian Americans, Native Hawaiians, and Pacific Islanders, by the fact that you already have patients on your governing board, that many of you have patient advisory councils or other patient engagement tools in place, means that you already have, again, a head start on these kinds of elements, but really just engaging those consumers and patients in looking at your quality data to identify what areas of improvement there might be, what disparities there might be, and really trying to improve that patient experience. Setting your own goals for quality improvement, those areas, whether again it's in patient experience or in particular disease-specific or other kinds of net quality measures, are something that are going to be really important for you to meet this last standard. So the bottom line is that many community health centers are participating in these various federal, state, and other medical home initiatives. The great news is that many of you ACHO members and other community health centers have actually achieved this National Committee for Quality Assurance recognition, have met these 6 standards that I've just discussed, and are well on your way to improving quality through the implementation of the model. And then the other good news is that there are lots of resources available to help you as you move along, and lots of examples and experience to learn from in terms of what challenges there might be and ways to overcome those particular challenges. So I'm going to discuss 2 particular articles that were recently published in this special issue of AAPI Nexus by UCLA, and these all focus on actual member community health centers, comments, and the first article with 4 centers, Waimanalo, Kahili, Kaliki Palama, and Waianae, and West Hawaii Community Health Centers in Hawaii. These 4 community health centers partnered with the Hawaii Primary Care Association and the license provider to organize themselves to really focus on improving diabetes care and on depression care for some of them. Looked at how these 4 community health centers following and being able to achieve their goals in their individual care plans. The challenges for this were the pilot program. Their questions had to be identified and enrolled in order to have this additional level of focus and attention. And ultimately, in a patient-centered medical home, we don't want to do this for just a select number of patients, but we want to do this for every patient. And so this idea of, are we going to be able to do this, to spread this throughout our entire patient population, is going to be a scaling challenge that community health centers will have. And then finally, while the results were very, very impressive for the 18-month, results are going to be sustainable, not just for these and across the health center, it's also going to challenge. The second example, B. Wang Community Health Center in New York, focused on were mothers who have hepatitis B, and their goal to use the patient-centered home model by creating care plans for these pregnant moms, and care teams really focused engaging those pregnant moms throughout the course of their pregnancy to eliminate the perinatal transmission of hepatitis B to their newborn infants. And what realized and put in place was that they could do a lot with themselves and the care that the moms received at Charles B. Wang Center, but it was equally important to engage the other providers. And so again, there's no coordinating the care, acting the care, even beyond the primary care site. So it meant doing some proactive outreach to the hospital labor and delivery department and making sure that they knew that these pregnant women were coming in for their labor and delivery so that they could do immediate vaccination upon childbirth, and needing to coordinate pediatricians that were going to take care of those infants, whether they're at Charles B. Wang or someplace else, to make sure that they have the follow immunizations and vaccinations for those newborn, to monitor the health themselves. They used the patient's and what it needed to happen for that providers to need to interface with over the course of the pregnancy. Through great news that Charles B. Wang has reported is that since to perinatal transmission, an effective model to try to take care of this particular issue. And so these are two examples where community health centers in the ACCHO network have already successfully used the model of the patient-centered medical home to improve health outcomes, and that should be great inspiration for all of us. ACCHO has also put together other practice transformation resources that will go through each element of the patient-centered medical home model and talk about how you can be supported in implementing or doing better in the elements that are required. I also want to commend a whole series of resources from what is known as the Safety Net Medical, funded by the Commonwealth Fund and was based at Qualis Health in Washington State. And they have also put out some really, really terrific, very detailed, very pragmatic, very helpful resource guides. One of the things that they discuss that I'm going to talk about briefly is how we pay for all this in the various payment models, either incorporating it into payments from health plans or others through grants, or structuring them as bonus payments or shared savings payments down the line. And so again, we can talk more in question and answers about how these models are being paid for. It also often depends, for example, in the 2703 health home model that many states are incorporating, that the additional services that a health home for individuals with chronic conditions might need in those 36 months would actually be fully paid by the federal government through that health home model. And so there's various ways that there are payments for this and being structured. The other resources in the Safety Net Medical Home Initiative are about things like how do you create panels of your patients. One of the biggest challenges that many of the community health centers in the Safety Net Medical Home Initiative phase. And so there's a lot of focus on how to do that in the best possible way. And then all these issues around how do you enhance access, how do you make sure that there's good communications through the team and with the patient, family, and caregiver. How do you implement quality improvement strategies and measures? How do you do the care coordination with individuals and providers outside of your community health center? And again, these are all specific to community health centers, and so these resources are really going to be useful for you. And so finally, some concluding thoughts are that there has been great evidence that medical homes are going to be a promising model for achieving the quality improvements that we are going to be aiming for in the triple aim, that there could be additional payments and technical assistance to do this in this period of time of healthcare reform implementation, and that increasingly this is going to be a model that every primary care provider is going to have to adapt to. So again, this recent legislation on Medicare, if you're going to be a Medicare provider, you're also going to have to be a primary care provider that looks at and ultimately becomes a patient-centered medical home. For community health centers serving Asian Americans, Native Hawaiians, and Pacific Islanders, I think we also have an opportunity in our community health centers to do more than what's required by standards like the National Committee for Quality Assurance, patient-centered medical home standards, to really take to heart this whole person care orientation, but also to introduce concepts of prevention and health equity. And let me talk about those momentarily. So at community health centers, we have done a lot of work to integrate behavioral health into primary care. And again, this increasingly is a small part of the current standards, but it's an opportunity to really use that integration that has already been happening in our community health centers to really provide that whole person care for our patients. Similarly, many community health centers are integrating oral health care into our primary care services. And so this is another place in which community health centers are actually going to have a competitive advantage over physician practices that will never be able to integrate oral health services into their physician practice. They may be able to do a little bit of behavioral health, but they'll never be able to do oral health. So from a competition point of view, this will be always an advantage that community health centers will have, but it's something that community health centers need to pay attention to. And then finally, in terms of prevention, really the health education, the community engagement, the community empowerment elements of the work that our community health centers do, particularly with our Asian American, Native Hawaiian, and Pacific Islander populations. We can also take advantage of really integrating those other departments and services and programs to really take the longer, holistic view of what optimal health for our patients and our communities might be. And then finally, to really pay attention to the equity issues. We'll talk a lot more in the final webinar on the culturally and linguistically elements of practice transformation, but clearly patient-centered medical homes can call out some of these elements. And again, this is a competitive advantage that community health centers will have in trying to really advance these issues. It's something that's required for everyone, but it's something that community health centers, particularly those serving Asian Americans, Native Hawaiians, and Pacific Islanders, can particularly excel at and be, again, a competitive advantage for them. And so the last thing is that we all need to do better in designing patient-centered healthcare, and the concept of this being really patient-centered and family-centered and community-centered is increasingly an important concept, but we can all do much, much better. There's lots of commentaries and conversation about what that really means, and the patient-centered medical home is clearly a starting point and a framework for that, but we can do so much better, and we need to do so much better if we're really going to turn the healthcare system around to achieve the triple aim and really be much, much more patient, family, and community-centered. So let me end there. Remind you that there are future webinars on accountable care and payment reform next week, and then the week following that, highlighting the culturally and linguistically appropriate services within practice transformation. But let me stop there and open it up for questions and comments also, especially for those of you from some of the community health centers that participated in the patient-centered medical home improvements that I mentioned in the 2 articles.
All right, thank you, Ignatius. We will now begin the question and answer section of our call. As mentioned in the beginning of the call, we will start by answering questions submitted to us via the chat function. If you would like to submit a question now, please do so in the chat box on the right-hand column of your GoToMeeting screen. So Ignatius, here's a question for you. Can you explain the levels of PCMH recognition? What differentiates one level from another?
So I didn't spend a whole lot of time talking about the 3 levels of recognition because the scoring for the 6 standards and the various elements and factors is very complicated. There's some individual parts of the 6 standards that are called must-pass, and so every patient-centered medical home, in order to get recognized, has to pass those elements, but there's only one must-pass element in each of the 6 standards. And then it's like other tests, you have to accumulate enough points by passing enough of meeting the requirements for enough of the other parts of the 6 standards to reach a cumulative score. If you reach a certain level, you are considered a level 1 patient-centered medical home. If you score more points, you're considered a level 2, and then ultimately you want to get to a level 3. But even a level 3 patient-centered medical home under the National Committee for Quality Assurance Standards doesn't mean that you've met every element of the 130-something elements in the 6 standards. And so it is also a continuum that NCQA recognizes that practices are in this process of continuous improvement, and they wanted to do some recognition for those that were starting, but not quite at that optimal threshold of a level 3 recognition. Most payment systems are now requiring a practice or a community health center to actually have the level 3 recognition in order to get some of the payments. So ultimately, that's where everybody's going to need to go.
All right, thank you. And the next question is, what's the difference between PCMH and ACO?
So I'm going to spend a lot more time talking about this next week. So a patient-centered medical home really focuses on primary care and the transformation of that primary care practice to, again, be the central place for that patient and family and caregivers, and to provide that continuous long-term relationship with that patient and the primary care provider. It does require the primary care provider to do this level of coordination with other healthcare providers, but it's really focused on primary care. Accountable care organizations take a broader view and are going to be different systems and models and organizations that include primary care as a base, but will include hospitals, specialists, all kinds of other healthcare providers. And so it will bring all those other providers into accountability and shared risk and shared profit or savings or payment. And so it's much more complex than patient-centered medical homes, but an accountable care organization needs patient-centered medical homes as primary care providers as a core element, but they're going to need much, much more. And we'll talk about this next week on the webinar on ACOs.
All right, thank you. And we also have a comment that was submitted. Some insurers are refusing payment for PCMH services because they offer some duplicate services like care coordination. And so that was just a comment.
Right. So again, different health plans are, depending on the state Medicaid program, might be encouraging those health plans to move all their providers in their network into patient-centered medical homes, or ultimately only contract with providers who are recognized as patient-centered medical homes. And what health plans might do that are in some states are supporting those patient-centered medical homes with some of these additional care coordination and other kinds of services. Helping them with things like health information exchange and health information technology. There are other examples I'm most familiar with in Colorado and Oregon, where they're calling them coordinated care organizations, or CCOs, as opposed to PCMHs or ACOs. And these are Medicaid funded organizations in those states that are providing those kinds of wraparound services. Some of them are health plans, but some of them are community health centers, and some of them are community-based organizations and other organizations. In Oregon, some of them are actually led by behavioral health organizations. And so there's all kinds of variations and varieties. And then, again, the payment of who pays for the care coordination and other services varies depending on what the model is.
All right, thank you, Ignatius. This concludes the Q&A session. Before we hang up, I want to remind you all that if you have not done so already, there is still time to register for our next webinar that Ignatius mentioned earlier, which will be on Wednesday, April 29th at 12 noon Pacific Standard Time. This next webinar will focus on accountable care organizations and its implications for community health centers serving Asian Americans, Native Hawaiians, and Pacific Islanders. Register for this webinar at www.apsha.org. For those of you who have registered already, thank you, and we look forward to speaking with you during our next webinar. Thank you and goodbye.